Hello, everyone, and I'm very happy to see all of this gathering today. This is Professor Amr Hosseini. I'm a medical director, and also I am the vice president of the WKE, the World Kidney Academy, and the president of the World Institute of Critical Care and Emergency Medicine. And today is very special to us because we have an introductory meeting to our next week CRRT crash course. This is the first of its kind unique virtual workshop on 18th and 19th of November. So next week on Tuesday and Wednesday for 2 days, 6 hours every day. So it's very important. And today we will have a brief introduction. So Dr. Mahmoud Sheikh is going to give us a case-based discussion. And Dr. Kamal
هو ده هنا بتاع الدكتور فاضل موجود.
Dr. Fadil, please mute yourself. Then Dr. Kamal Attar will give a CRRT prescription demonstration on the CRRT machine. Dr. Hazem Abshusha is going to give clinical.
It would be the pericardium thicket, but I just said that's hard to see on echo, so you might want to be.
So Farida, there is some background noise. Dr. Hazem Abshusha is going to give us some clinical practice on vascular access on the CRRT machine. Dr. Amrit Korblani is going to give a very smart introduction to the use of online simulator and artificial intelligence in the CRRT prescriptions. So again, it's very important and it's a state-of-art virtual workshop. So wherever you're at, you can access the materials and you will have access for these high quality educational materials, not only for November 18 and 19, but also on a smart platform for 3 months. We have an international experts gathered to give you this educational contents. And also we have students and attendees from more than 38 countries from all over the world. So 2 days of immersive virtual workshop training with world-class nephrology and critical care experts. And you will be learning intensively the CRRT prescription principle, troubleshooting, settings, and advanced application. And also by the end of this workshop, you should acquire the essential knowledge and practical training in the CRRT. You're going to master the CRRT prescription, and you're going to understand the core principle and various modalities of slow continuous therapies. And you will learn how to set up and troubleshoot and optimize the CRRT prescription and improve your patient outcome and explore novel CRRT technologies and the clinical application. So if you are very naive, very new to the CRRT, or if you have at least basic knowledge or even advanced knowledge, you're going to master the art of CRRT prescription, and you're going also to master the art of fluid assessment, fluid balance, hemodynamic monitoring, volume assessment, ultrafiltration, and will help you to apply this knowledge in simulated real-world patient scenario to improve your patient outcome and improve your clinical practice and standard of care. So congrats for those who joined, and the application deadline would be Saturday, November 15th, so only 5 days. So our aim is to make the CRRT practice less intense. So when they call you for a patient who needs a CRRT, you're not going to panic, and it will be very, straightforward process, and actually it will be fun. With that, I'm going to let Dr. Mahmoud Sheikh give the first presentation, which is a case-based discussion. And it's very nice presentation that he prepared, and he's going to give you about 5 to 6 cases who needs CRRT and he's going to help you how to prescribe and how to manage the CRRT prescription and troubleshooting.
Bismillah ar-Rahim. Thank you, dear Professor Dr. Amr Husseini. Good day, everyone, and welcome to the introductory meeting for CRRT crash course taking place on November 18th and 19th. I'm Dr. Mahmoud Sheikh, nephrology consultant, CCN board member, and educator with World Kidney Academy. In our next workshop, we will bridge the gap between ICU and nephrology units, exploring how to prescribe CRRT safely and to optimize therapy to manage also complications and troubleshooting real case scenarios. It's designed to help every clinician, whether working beside in the ICU or managing therapy from the nephrology service, to feel confident and precise in applying CRRT principles. During this introductory webinar, we will also go through 5 clinical case scenarios, each one focusing on a key area of CRRT practice, from prescription strategies and anticoagulation to effluent dosing, circuit troubleshooting, and filter performance. These questions set the stage for what we will discuss in depth during the upcoming workshop, where we will expand on each topic using interactive cases and evidence-based reasoning. So stay tuned, take notes, and get ready. Together we are going to master CRRT practice. Starting with case 1, optimizing filter life in CVHDF, we have a 70-80 kilogram man on CVHDF who is experiencing recurrent filter clotting every 6 to 8 hours. Let's look at his current prescription. His blood flow rate is 150 millimeters per minute. His effluent flow is 2 liters per hour. His dialysate is 500 millimeters per hour. Replacement fluid is 1.5 liters per hour, all given post-filter. Now moving to the clinical goals, what this patient really needs. Here it needs strong control of urea and potassium level, and to prevent filter clotting, particularly from hemoconcentration, and also needs a liver dose of approximately 22 to 25 millimeters per kilogram per hour. So the main challenge here is to balance adequate clearance with filter longevity, especially given his repeated clotting episodes. Now let's test the logic, which change best meets all 3 goals he needs. Option A says, keep the same split, just raise the total dose of 3,500 millimeters per hour. That might look like more clearance, but it doesn't fix hemoconcentration, and high doses haven't shown survival benefit according to the studies. Option B, shift to a dialysate heavy split, for example, 1,500 millimeters per hour of dialysate and 500 millimeters per hour of replacement. Okay, this improves small solid diffusion, but again, it doesn't address the main issue of hemoconcentration and circuit reclotting. Option C, keep the same total split, but move most of the replacement fluid to the pre-filter side. Okay, this one directly tackles hemoconcentration and lower filtration fraction and prolonged filter life while maintaining the same overall dose. Option D, switch to scuff. That's pure UF, no clearance, so definitely not meeting all 3 goals. And option E, reduce the blood flow to 100 millimeters per minute. That would actually worsen hemoconcentration and raise filtration fraction more. So the best answer here is to keep the split but move most replacement fluid to pre-filter. Let's talk about when to favor each approach in CRRT. This is the practical rule of thumb we use as a bedside. Choose pre-dilution when clotting is a recurring problem, when a hematocrit or blood viscosity is high, or when anticoagulation needs to be minimized. Pre-dilution lowers filtration fraction and usually prolongs filter life. That's why it's favored in circuit with frequent clotting or limited anticoagulation options. On the other hand, choose post-dilution when you need the best small solid convective clearance, and you can safely control hemoconcentration with adequate blood flow, citrate or heparin anticoagulation, and careful monitoring of filtration fraction. Of note that many centers actually run a mixed CVHDF setup, combining some pre- and post-replacement fluids to balance solid clearance with circuit longevity. No matter which approach you use, the key here is to keep tracking your filtration fraction, KMP, trends, and the delivered versus prescribed dose, because that's what defines real performance, not just the numbers you see on the machine. Let's look at the pre-dilution solution and why it's often the right choice when we are dealing with recurrent circuit clotting. The pre-dilution effect lowers hematocrit and blood viscosity right at the same membrane surface. By diluting the blood before it enters the filter, we reduce sludging and maintain smoother flow through the fibers. This leads to a reduced filtration fraction, meaning less heme concentration and lower risk of clotting within the circuit. As a result, we get prolonged filter life, maintaining dose delivery and uptime, especially when the blood flow is kept at or above 150 millimeters per minute. Here is the key insight. Pre-dilution does slightly dilute solid clearance, so you lose a little clearance efficiency, but at the same total effluent dose, you can maintain stable therapy and much better uptime. In other words, it directly solves the heme concentration problem that causes premature filter clotting. The question, why do the other options fail? Option B boasts diffusion for small solids but doesn't fix the heme concentration issue. Option A wastes solutions and still clots because the underlying mechanics haven't changed. And remember, very high effluent doses don't improve survival according to the KDIGO guidelines. Option D and E fall short on solid goals and may even worsen clotting, especially if blood flow is low, since that increases the filtration fraction. So pre-dilution isn't just a technical trick, just strategic adjustment that keep your circuit alive, your dose consistent, and your therapy efficient. Let's move to the case 2, ultrafiltration in cardiogenic shock using CRRT. This is a 72-year-old man presenting with cardiogenic shock and ERDS. He is severely fluid overloaded with a positive fluid balance of more than 9 liters. His current venous pressure is 18 millimeters of mercury, indicating significant venous congestion. Laxity is elevated at 3.8 millimoles per liter, suggesting ongoing tissue hypoperfusion and injury. He is currently on dual vasopressor support, norepinephrine at 0.28 micrograms per kilogram per minute, and dobutamine at 7.5 micrograms per kilogram per minute. Hemodynamically, his MAP is between 60 and 64 millimeters of mercury, heart rate around 18, and urine output only 0.2 millimeters per kilogram per hour. Lung ultrasound shows diffuse B lines consistent with pulmonary congestion. Altogether, this case represents the classic scenario of cardiogenic shock with fluid overload, where controlled UF becomes the key strategy to relieve venous congestion while maintaining perfusion. Now let's decide on the best initial UF plan for this patient in cardiogenic shock. Option A suggests starting 300 millimeters per hour net UF immediately. Okay, that's aggressive and unsafe in a hemodynamically unstable patient. Option B, 0 UF for 6 hours. This might protect perfusion temporarily, but it doesn't address the ongoing volume overload or pulmonary congestion. Option C, 50 to 100 millimeter per hour with hourly hemodynamic reevaluation. This represents a cautious physiology guided approach. It allows gradual decongestion while continuously assessing the patient response. And option D, stop all IV fluids and use dialysis only. This ignores the hemodynamic instability and risk further hypoperfusion. And option E, fluctuating UF from 0 to 500 millimeters per hour based on momentary mean arterial pressure. This introduces instability and can cause repeated shifts in venous return and perfusion. So option C is the correct one. Start slow and around 50 to 100 millimeters per hour and reassess frequently. Remember, in cardiogenic shock, UF is not about speed, it's about control and continuous monitoring. Now let's highlight the gentle ultrafiltration strategy. the winning approach for patients with cardiogenic shock or those requiring vasopressor support. Step 1. Start conservative. Begin with slow and steady rate around 50 to 100 millimeters per hour, which translates to roughly 1 to 1.5 millimeters per kilogram per hour. Step 2. Monitor hemodynamic and reassess hemodynamics every hour using point-of-care ultrasound, evaluating IVC diameters, B lines, and perfusion markers to judge tolerance and guide adjustment. Step 3. Titrate carefully, gradually increase the UF rates only as tolerated based on real-time clinical response and stability of mean arterial pressure. The evidence-based practice is clear in patients on vasopressors. A gentle and dynamic guided UF strategy prevents hypotension while still correcting fluid overload. Let's quickly recap the pitfalls. Option A, starting with 300 millimeters per hour, as we mentioned, is too aggressive and risk hypotension. Option B and D, either stopping UF or stopping IV fluid under treat the overload or prolonged congestion. Option E, fluctuating from 0 to 500 millimeters per hour, causing large hemodynamic swing that destabilize MAP. So the winning formula, as we mentioned, is simple: start slow, monitor hemodynamically, titrate with caution, and protect the perfusion while decongest. Moving to case 3 in CRRT and liver failure. This is a complex patient, 58-year-old man with septic shock and moderate liver failure, now developing stage 3 AKI. Is currently on vasopressor support, norepinephrine at 0.2 mic per kilogram per minute, and vasopressin at 0.03 units per minute. Looking at liver function, his bilirubin is 6.2 milligram per deciliter, and his INR is 2.1, indicating impaired hepatic clearance. For his vitals, heart rate is 112, MAP 64, and oxygen saturation 96% on room air. So overall, he's a hemodynamically unstable patient with multi-organ dysfunction, where managing CRRT in the context of liver failure requires careful adjustment of anticoagulation strategy and calcium balance monitoring. The question now, which buffer choice is best? Option A, bicarbonate 32 to 35 millimole per liter. Option B, lactate 40 millimole per liter per hour per liter. C, no buffer at all, 0. D, scuff without dialysate. E, high acetate solution. And the correct answer is A, bicarbonate 32 to 35 millimole per liter. Let's move to one of the most important buffer choices in CRRT, bicarbonate. The clear winner here in patients with liver failure or high lactate metabolism of lactate is impaired, which increase the risk of worsening metabolic acidosis if lactate-based solutions are used. Bicarbonate, on the other hand, is the preferred buffer for correcting metabolic acidosis during CRRT, especially in liver cell failure, because it restores pH balance independently of hepatic metabolism. Now, look at this matrix. On the vertical axis, we have safety, and on the horizontal axis, we have efficacy. In the optimal zone, you see bicarbonate-based solution at concentration around 32 to 35 millimoles per liter. They are both safe and effective, providing reliable acid-base correction without hemodynamic compromise. On the upper right, lactate buffers can appear effective, but in liver failure, they are unsafe because impaired clearance leads to vasodilation and hemodynamic instability more and more. In lower zones, acetate buffers are unstable and can cause severe hypotension, while no buffer system simply leaves acidosis uncorrected. So the clinical takeaway here is lactate-based solution may worsen lactic acidosis. No buffer leaves acidosis uncorrected, and remember, scuff removes fluid only, not acid. For acid-based control in CRRT, bicarbonate is the clear and safest winner in liver cell failure. Moving to case 4, rising venous pressure in CRRT. We have a 58-year-old trauma patient on CVV HDF using right femoral access. Over time, the venous return pressure has been steadily increasing. from plus 250 millimeter of mercury up to plus 320, while the arterial pressure remains stable at minus 120 millimeters of mercury. Both effluent and replacement flows are stable, meaning there are no major circuit or flow issue elsewhere. So the question becomes, what is the most probable explanation for this isolated rise in venous pressure? Let's review the answer choices for this scenario. Option A, venous limb kink or thrombus at the catheter tip. Okay, that would cause an outflow obstruction and lead to a rise in venous pressure. Definitely something to keep in mind. Option 2, filter clotting. This usually raises both pre-filter and post-filter pressures, not just the venous pressure. Option 3, air trap, partial obstruction that tend to cause intermittent or erratic pressure changes rather than a steady rise. Option 4, mechanic transducer error. That's a mechanical issue, not a true physiological rise in pressure, and often resolved after checking or recalibrating the transducer. And lastly, option 5, hypovolemia, and that would lower pressures, not raise them. So keep this in mind as we analyze which mechanism best fits the pressure pattern seen in this case. And the correct answer here is venous limb kink or thrombus. Let's break down the reasoning. Selective rise in return line pressure always points toward an outflow obstruction. That could mean a catheter tip thrombus or kink in the line, or sometimes even a vessel spasm. Simply repositioning or straightening the line often corrects the pressure and confirms the diagnosis. Now let's look at the why other options doesn't fit. As we mentioned, filter clotting would raise both pre and post filter pressures, not just the venous one. Air trap or transducer error cause erratic, not steadily increasing pressure, and hypovolemia would actually lower pressure, not raise them. So the key teaching point here is simple but crucial. When you see isolated venous pressure elevation, think outflow problem, usually at the catheter site. Moving to a last case, case 5, severely hypocalcemia in CRRT. We have a 68-year-old man on CRRT using regional citrate anticoagulation. He developed a new hypotension and tetany, clear signs of acute hypocalcemia. His calcium infusion is running at 80 millimeters per hour of 10% calcium gluconate. Now let's look at his labs. His systemic ionized calcium is 0.7 millimoles per liter. That's critically low, and his total calcium is 2 millimoles per liter, which is still within the normal range. And his post-filter ionized calcium is 0.25 millimoles per liter, which is right on target. Finally, ECG shows a prolonged QT interval consistent with severe hypocalcemia. So the key here is normal post-filter calcium, but critically low systemic calcium. This will guide us towards the right diagnosis in the next slide. Now, the question is, what's the most likely cause of his severe systemic hypocalcemia? Let's look at the option carefully. Option A, citrate accumulation from liver failure. That would cause both high total to ionized calcium ratio and metabolic acidosis. But that's not what we are seeing here. Option B, calcium infusion line disconnection or precipitation. That could definitely lead to a drop in systemic calcium while post-filter calcium stays normal. Keep this one in mind. Option C, excessive citrate dose. That would lower both systemic and post-filter ionized calcium, which doesn't match our data here. Option D, inadequately dialysate flow removing citrate. That would actually raise citrate levels and alter post-filter calcium, again not consistent here. Option E, low magnesium causing secondary hypocalcemia, possible but it doesn't explain the acute and isolated drop in systemic calcium with normal post-filter levels. So we will need to decide which option best fits the pattern. We will reveal that in the next slide. Let's look at the correct answer, calcium infusion failure. This happens when calcium infusion line is either disconnected or there is precipitation inside the line. Here is the key diagnostic clue. when your post-filter ionized calcium is normal, but your systemic ionized calcium is critically low, that tells you filtrate removal is fine. The problem isn't with citrate, it is a failure to replace calcium. That failure is usually due to kinked or disconnected calcium infusion line. So in this case, the post-filter ionized calcium is normal, around 0.25, but the systemic ionized calcium is critically low, about 0.7. That pattern confirms a calcium infusion problem, not citrate toxicity. Let's look at why the other option doesn't fit the scenario again. First, citrate accumulation like liver failure, that would raise total to ionized calcium ratio above 2.5 and cause metabolic acidosis, and this is not what we are seeing in this case. Next, excess citrate dosing. If that were the case, both systemic and post-filter ionized calcium would drop. But in our patients, the post-filter value is perfectly normal, so that doesn't add up either. Then there is an adequate dialysis flow. If the dialysis flow were too low, citrate levels would climb, which would push the post-filter calcium out of target. Again, not happening here. Finally, low magnesium. It can coexist, yes, but it doesn't explain the acute change when the post-filter calcium is normal. So here is the clinical picture. If your post-filter ionized calcium is normal, but the systemic ionized calcium is low, that's point to calcium replacement problem, not a citrate accumulation. Thank you all for attending. We are looking forward to seeing every one of you at our next CRRT workshop. Stay connected with us and follow our YouTube channels for more updates and sessions. Thank you. Goodbye.
Thank you so much, Dr. Mahmoud al-Sheikh, for this very nice case-based discussion. And during our next week virtual workshop, we'll have several and many of these case-based discussions. Dr. Mahmoud al-Sheikh, I think, prepared 30 cases, and Dr. Fadel Ibrahim prepared another 30 cases. So these are just a few samples of whatever you're going to see in our next week workshop. Now it's our time to have very nice demonstration on the CRRT machine, how to prescribe and how to follow up on your prescription to optimize the CRRT and to improve your patient outcome. Dr. Kamel Attar, who is a senior consultant at Baxter International, did this demonstration on the CRRT machine to try to mimic the real life cases.
When prescribing the CRRT prescription, usually physician will start with the blood pump speed. Our case, it's a mandatory 140 ml per minute. So this is the best blood pump you can get because of the access. From there, you try to find the dosing. What's the right dosing for CRRT in this case? Using the KDIGO criteria, we prescribe 30 ml per kg per hour to try to achieve 20 to 25 ml per kg per hour. 30 ml per kg, patient is 100 kilos, 30 times 100 is 3,000 ml per hour, means 3 liters per hour. Now, 3 liters of what? Infusate, dialysate, or UF. Most of you opted to a UF 0. This patient does not look overloaded. So most of you prescribed 0 ultrafiltration. We're left with 3 liters of prescription. Are we going to use dialysate or are we going to use replacement? Convection versus diffusion. Now, according to your theoretical training, of course, we use diffusion to remove, mainly to remove small molecules. To remove large and middle molecules, we try to use convection. So in some cases, maybe some of you prescribed 3 liters per hour, 1.5 liter dialysate, being mainly a small molecule problem, and another 1.5 liter of replacement. Some of you made maybe half of that as pre and half of that as post-dilution. How do we make the decision between pre-dilution and post-dilution? Well, pre-dilution, you have the advantage of the blood coming into the filter quite thin, and therefore you have less likely for clotting. Post-dilution, you make the decision built on efficiency. So what do you want right now for this patient? You want more efficiency or you want less clotting? Therefore, given this case, some candidates prescribe maybe 0.75 pre, 0.75 post-dilution. They also, most of you prescribe 0 heparin for that patient. Why? Because the platelet count is 70,000. Most of us would be very careful prescribing heparin. Some of you prescribe half dose heparin. For that example, we will go with the zero heparin prescription. Also, there is a choice. What is your fluid choice? Some of you prescribe potassium 0, some of you prescribe potassium 2, based on the case of the patient being hyperkalemic potassium 6.2. Most of us opted to a potassium 2 or a potassium 0 fluid. Now, implementing that prescription on the machine, remember blood pump 140, dialysate 1.5 liters, pre-dilution 0.75, post-dilution 0.75, zero heparin prescription, and potassium 0 fluid. When implementing that on the machine, we will be able to judge whether this is a high clotting risk prescription or a low clotting risk prescription. We will be using filtration fraction to judge whether it is a filtration fraction that's more likely to clot, with filtration fractions above 25% in fully heparinized patients, but above 20% in non-heparinized patients, like the one we've just prescribed. So we will try to target to achieve less than 20% filtration fraction. What is filtration fraction? Filtration fraction is a ratio that will be calculated by the machine. You will see the results for self. It takes in account how much you use UF, 0 in this case, how much you use pre-dilution, 0.75, how much you use post-dilution, 0.75, what is your blood pump speed, 140, and what is the patient hematocrit, which is 36%. With all these calculations in a built-in formula, the machine will show us what does that prescription look like on the machine itself. Let's see. Now the nurse has received the doctor's prescription, and now it's the time to implement that prescription on the CRRT machine. The purpose of the exercise is to try to see how those parameters will reflect on the actual CRRT prescription. Nurse starts by entering the blood pump speed, as we remember, 140. And then pre-blood pump, if you can remember, 750. Dialysate 1.5 liters. Replacement, which is post-dilution, 750. Patient fluid removal, as we can remember, was 0, but also confirming all parameters. Heparin, 0 heparin prescription. Remember, this is the heparin pump. Nurses can prescribe heparin with a number of international units per hour. Some of you prescribe 5 international units per kg per hour. In our patient case, that will be 500 international units per hour. And therefore, the nurse will prescribe this heparin using the heparin syringe, entering it here, depending on how much concentration of heparin, maybe 1 ml, 2 ml per hour would be the right dose to be administered through the heparin pump. But in our prescription case, it was 0 heparin prescription, so we confirm that there is no heparin on this one, confirming all, then and this is how your final CRRT prescription looks like. Blood pump 140, pre-750, dialysate 1.5, replacement 750. 0 UF and the heparin as 0 heparin prescription. Of course, also using 0 potassium solutions, the dialysate or the hemosol, whatever solution you have as 0 potassium would be completing your prescription for this patient. Continue and start the CRRT prescription. You can see that this is how the main screen looks like in our case of your prescription. You will see the patient's weight, again 100 kilograms. You will start the CRRT in CVHDF mode. See the blood pump, pre-dialysate replacement. This delivers a dose of 30 ml per kg per hour, which is a sufficient dose, as we explained. before, but the filtration fraction, as you can see, is very high at 26%. Remember, patient is zero heparin prescription with filtration fraction 26% being above 25%. It is a very high risk clotting prescription. This prescription is probably going to clot and will possibly not continue for a 24-hour CRRT prescription. 12 hours into CRRT, his labs are out. Serum creatinine is now 2.6 milligram per deciliter. Serum potassium is 5.5. What changes to the CRRT prescription would you make? In 12 hours of CRRT, serum creatinine dropped from 4.2 to 2.6. For me, this looks like an amazing clearance. Clearance is good of small molecules. Potassium dropping from 6.2 to 5.5. Remember, in CRRT, we target correction of electrolytes over 24 hours. So when we achieve that results in 12 hours, it seems like a good result. For me, I'll probably change nothing. Some of you opted to go from potassium 0 to potassium 2, which is not a bad decision, in this case, to try to prevent hypocalcemia, which is a complication of CRRT usually seen in prolonged times of CRRT or very high dose CRRT. At 18 hours of CRRT, patient develops a fever and a tachycardia with a heart rate 110. His MAP is now 60. What changes to the CRRT prescription would you make? Remember, our CRRT prescription blood pump speed was at 140. We were using 1.5 liters of dialysate. We were using 750 of pre and 750 of post dilution. We were using zero heparin prescription. We were now back to potassium 2. This is the current CRRT prescription. Now, the patient obviously is developing, or actually developing an AKI with sepsis, and the septic condition is worsening. So we're seeing fever, we're seeing tachycardia, we're seeing a drop in MAP. Most of us now would think of doing more convection than diffusion. So we're still using a CVV-HDF prescription, but we'll try to use this 3 liters per hour to produce more replacement and to produce less dialysate. Now, this is going to be very difficult with the original CRRT prescription because we are already with a very high filtration fraction. Now, how can we actually reach good convection while maintaining acceptable filtration fractions? So the decision was made by the prescribing physician to increase the convection and reduce the diffusion to try to manage the bigger sepsis problem and the less of the AKI problem. So the problem now is with large middle molecules and trying to remove cytokines, interleukin 1, interleukin 6, TNF. So the decision was to do more convection, to remove more of the big fat elephant molecules in the patient. So we're going back there. Doctor changed the prescription to have 1 liter dialysate, 1 liter pre, and 1 liter post. In that case, having the same dose of 3 liters, but 2 liters of which, or 2/3 of which, being convection, and only 1/3 being diffusion. Let's see how that looks like on the monitor when we enter the prescription. So we go to adjust here, and we start the blood pump. We cannot change that. As we know, the maximum is 140 because of the limitations of the access. We change the pre-blood pump to try to make it up to 1 liter. We try to go to dialysate, reduce it from 1.5 to 1 liter. We go to replacement and we increase it from 7.5 up to 1 liter. So what does that look like? If you confirm all parameters, you will see that the dose is still 30 ml per kg per hour. We did not change the dose, but definitely much more convection and less diffusion. But what's the major problem with that, as you can see, filtration fraction went up to 33%. In that case, it's a very high clotting risk prescription. So when we are prescribing that, we have to already know that either within a few hours, we will receive alarms and we will do circuit change, or we can change or adjust something within the CRRT prescription to achieve what we mentioned earlier, as 20% maximum filtration fraction in non-heparinized patients. How can we achieve that? As we remember, the formula starts by increasing the blood pump, which we cannot do. What else can we do? Maybe reducing the post-dilution. So if you can see just one step, reducing the post-dilution from 1 liter to 0.5, let's see how that looks like in terms of filtration fraction. We adjust, we cause the replacement, we go to the 1 liter, and we make that 0.5. If you confirm that, filtration fraction will go down from 33% down to 25%, which is a good change. 25% seems to be acceptable. What decisions can we make now? One decision is to fully heparinize the patient. Make the decision that platelet count 70,000 is okay. I can now introduce heparin, give a full dose of 10 international to 15 international units per kg per hour. Patient is 100 kilos. I prescribe 1,000 to 1,500 international units per hour and continue my CRRT. If I insist on doing zero heparin, I need to do further actions to reduce my filtration fraction. Another action is also to reduce the pre-dilution. So the pre-dilution is a factor that reduces clotting. It's also a factor that causes pressure on the filter. So going down from 1 liter pre-dilution to half a liter pre-dilution will reduce the filtration fraction. Let's see that. Adjusting it, going to pre-blood pump, and reducing 1 liter to 500 will also further reduce the filtration fraction of our patient. Now we have reached 18%. This is an acceptable filtration fraction. But look what happened. We went down with the dose from 30 ml per kg per hour to 20 ml per kg per hour, which is not acceptable. As we saw from the KDIGO guidelines, we need to prescribe 30 ml per kg per hour to achieve somewhere between 20 and 25 ml per kg now. How can we compensate for that reduced dose of CRRT? Well, we can increase dialysate back again to 2 liters. So compensating the half liter we took from the pre and the half liter we took from the post and put it all in the dialysate. We adjust, we press dialysate, we go from 1 liter up to 2 liters of dialysate. Confirming that you have achieved 30 ml per kg per hour with filtration fraction of 18%. Now, some of you are going to say, well, we reduced convection. You did not increase convection. You ended up with the right dose, but instead of increasing convection, we end up reducing convection. So what is the answer to that? The answer to that is that the CRRT prescription is more of a science and an art than a statement. So that means that in order to reach good convection, you need a good catheter in a patient who is 100 kilos. So you have to either have a perfect access, then you can play with the convection as much as you want, or a smaller patient, which we do not have, or a less hematocrit, which we cannot control. So in this case, what we can control is the CRRT prescription, and it's a trade-off. You want high quality convection, at the same time less clotting. You want to have a good clearance of large molecules, but you want to have a filter that stays for 24 hours. Which is more important right now? You need to make your trade-offs built on the parameters that we explained in our theoretical and our practical session today, and in your previous theoretical studies. Good luck with the rest of your CRRT training. Again, my name is Dr. Kamel Attar. I wish you all the best of luck.
Thank you so much, Dr. Kamel. Very nice demonstration. And in our next week virtual workshop, we'll have several of these CRRT machine demonstration with Dr. Kamel Al-Attar. So now I'm going just to share with you a very brief introduction about also our next week virtual workshop that you are going to have for 12 hours. So 6 hours on Tuesday and another 6 hours on Wednesday. Here are the steps. So everything will be on the platform. You should have already received your login credential, username and password, so you can log on to our platform that will have all of our recorded lectures, MCQs, clinical case scenarios, and the exam. Then your next step, so make sure you have already received your email with the login credential. If you haven't, probably you're going to receive it in the upcoming day or two. Step 2, try to log into the platform at any time to check that everything looks good. Step 3, join sessions 1 and 2 live through the platform next week. Then step 4, once session 1 and 2 are completed, refresh the page, then you will have an exam. This exam is not to judge you or to evaluate you, but it's rather also to teach you. It will have a lot of educational material. When you submit your quiz, you're going to receive the best answer with explanation why the correct answer is correct, why the distractors are incorrect. Step 5, continue by joining session 3 and 4 on the first day. Then step 6, after completing session 3 and 4, you need to refresh the page. Then you're going to receive your exam. So here is a login. So you will have your login info. You can put your username. You can put your password here. Then you will have the chance to go in the platform. So of course, you are not going to see everything now, but you're going to see everything by next week. So after you do this, you will see the CRRT crash course, and you can you're going to start the course. Then you can see what we'll have for our next week. So it's very essential that to prepare yourself. Also, you can read about the CRRT, and you can prepare some questions if you have any. So it will be very live demonstrations, interaction between our tutor, board member, educator, and our attendees. Also, you can change your password, and please make sure that you will remember your password if you change it. So please don't ask that you forget your password. So try to remember your password. If you have any question, IT question, any admin question, please contact Ms. Farida El-Wakil. She is the one who is behind all of this. And you can text her on WhatsApp or on your cell phone, or also you can email her. Her email address is here. With that, we are going to have another 5 and 5 minute brief presentation. The first one will be by Dr. Hazem Abu Shusha, who is going to give us a very brief introduction about vascular access, which kind of vascular access and what kind of complication and the problem we should anticipate with CRRT. Then it will be followed by another smart AI presentation.
On alternative renal replacement modality, veno-venous therapy are the standard now, but trying to use an existing chronic fistula or graft, the one that being used for chronic dialysis patient for acute CRRT, is strongly discouraged. The concern here is about repeated needle trauma and to the fistula or graft, potentially causing permanent damage to the vessel or to the vessel wall or to the graft wall. So you don't want to jeopardize their long-term lifeline for short-term renal replacement therapy. So protect the permanent access here. And we have chosen the site, hopefully the right one. Now it's the time for the technical execution. Prescription is crucial here, and the catheter length isn't just a guess. It's a vital calculated variable. To reach the optimal placement zone, the length ensures that the tip of the catheter is in a large high-flow central vein, minimizing the chance of tip sucking against the vessel wall or causing mechanical irritation or trauma. And for the right internal jugular or external jugular, we can use 12 to 15 centimeter with a pre-curved or curved design. In the left side, we use a longer catheter up to 20 centimeter. In the right subclavian, the same as the right internal jugular. In the left subclavian, the same as the left internal jugular, but with a straight configuration. And for both right and left femoral, we use a longer catheter. So the ultimate goal here is precise catheter tip positioning, where exactly should the tip land for maximum efficiency and minimum risk. And here is some example. So regardless the material or the exact target, the cardinal rule is mandatory verification. The correct position must be confirmed using a chest X-ray for internal jugular line and abdominopelvic X-ray for a femoral line before that the catheter is ever connected to the CRRT circuit with no exception. So here a short catheter that been inserted in the left internal jugular, so the tip is lying in the left at the end of the left innominate vein, being at the end of the wall, at the tip of the wall, so making dysfunction of the catheter and leading to endothelial dysfunction. And here is also some examples of a malpositioned catheter. Here the catheter have been rotated into the axillary vein, and here the catheter have been inserted in the anterior thyroid vein in some patients. And given the dramatic variation in patient height and anatomy, clinicians need more accurate methods than simple estimation or using the standard cut length. We can use elegant technical shortcut like the Pieris formula, which predicted the catheter length needed to reach the optimal atriocaval junction or upper superior vena cava placement zone based on the patient's height. For the right internal jugular vein, the length required simply the patient height in centimeter divided by 10. This method boosts up nearly 90% accuracy in predicting the correct placement length. And for the left internal jugular, we take the same calculated length and we add 4 centimeter, account for the bend and extra path length. This adjustment often push the accuracy even higher, above 94% for the left side. The predictive accuracy feels like a massive step up from just grabbing the standard 15 or 20 centimeter cut, which are designed for an average patient and maybe too short or too long for a tall or a short patient. It transforms the procedure from historical guesswork into a form of precision engineering, improving the odds of achieving ideal flow and saving patients from potentially needing repositioning or suffering from early catheter failure due to poor placement. And so we have inserted the catheter using the estimated length. Now we need to confirm their position radiographically. The most reliable anatomical consistent marker for an standard anteroposterior chest X-ray is the right tracheobronchial angle formed where the right main stem bronchus branches from the trachea, just like here. The clinical protocol derived from anatomical study dictate that positioning the catheter tip exactly 3 centimeters below this angle on the X-ray ensured secure placement of in the lower superior vena cava or just at the atriocaval angle. Now moving to the insertion technique itself, without a doubt, ultrasound guidance is the recommended standard of care, especially for internal jugular catheterization. And that's why, because direct visualization allows the operator to see the target vein and confirm the patency in real time, and clearly identify and helps avoid adjacent critical structures such as carotid artery and pleura, giving precision and guide the needle entry precisely into the vessel lumen, and significantly lower the first pass failure rate and dramatically reduce mechanical complication. And don't even go beyond the strict sterile barrier protocol. The full attire and the full patient coverage, skin preparation, and any deviation from this protocol directly and significantly increase the risk of introducing bacteria at the time of insertion. And now testing the catheter by aspirating at least 5 to 20 millimeter of blood from each lumen. So if you're having any difficulty aspirating or flushing, indicates malposition and requiring reposition or exchange of the catheter immediately before use. But even when the insertion procedure goes perfectly by the book, mechanical complication can still occur. And this is the early complication starting from arterial puncture, bleeding, aspiration, laryngeal nerve palsy, puncture of the other structure, so going to the dramatic pneumothorax, area embolism, arrhythmia, and even the fatal one, pericardial tamponading, up to catheter kinking and tip malposition. And most of this complication can be avoided easily using the ultrasound guidance and post-insertion X-ray confirming one.
So this is just a demonstration, very brief introduction to whatever Dr. Hazem Aboushoucha is going to teach us next week. So all of these are just, a brief samples, but we'll have very extensive, long formats of this short presentation next week. So next we have only 4 minutes left to present how we can use the AI tools, the simulators, the online simulators, and the app to improve our CRRT prescriptions and also outcome. Because I think CRRT is a very optimal target and very good example to use the new technology, because it all depends on the technology. So let us see. Dr. Amrit is going to teach us how we can use online simulator and the app to improve our CRRT prescription.
This simulator, which is a CRRT alarm simulator, where you can practice CRRT alarm troubleshooting. So similar to the other simulator, you can use this at your own pace, but this one will let you pick a specific alarm. So let's say I want to simulate a low return pressure, and it'll walk you through the steps of what to inspect, what to do next, and it'll actually tell you the various troubleshooting steps for each alarm. After that, you can also do a practice mode where it generates a random scenario for you and doesn't tell you exactly how to do it to challenge you to work through it on your own. So the CRRT alarm simulator is another example where, again, you get these realistic alarms you can troubleshoot, and it's something that you can practice with your allied health team, even if you're not seeing that many cases, or if you have nurses who are onboarding for the first time as well. It also gives us some of those analytics, as in how long it's taking to resolve specific alarms. So hopefully it's something that can supplement your ongoing maintenance of competency. There are other valuable CRRT tools as well. And one other one that I want to show you, because I know we have limited time, is for some of those rare but critical scenarios. That thing that you may see once every 4 years, but when you see it, you're like, oh, I need to do a special CRRT thing here, and I wish I had a tool for that. So in this case, it's CRRT dysnatremia. When somebody comes in and they have severe hypo or hypernatremia, and you need to adjust your CRRT prescription accordingly. We know there's multiple methods of doing this. Many people modify their CRRT bags by adding water or sodium. That's considered the gold standard, but it's resource intensive, time intensive, and your center may not be able to do that depending on what's available to you. In adult medicine, many people will sometimes change the post-filter replacement or Y in a continuous infusion to modify the sodium of the entire circuit. But the downside with these strategies is, especially for small patients, so pediatric or small adults, sometimes those could impact your clearance or filtration fraction. So another tool that I created was a CRRT dysnatremia calculator. So with this one, you can put in your specific patient parameters, put in this patient's serum sodium, the sodium you want to achieve, typically we say within 6, and it'll tell you, based on your specific parameters, which of these infusions may be feasible and which of these methods may not actually work based on the filtration fraction you're targeting and the sodium you're targeting. So this is one that'll quickly tell you, if you want to do this way, you should do this. If you want to do this way, you can do this. And if you want to do this way, you can do this. So the CRRT dysnatremia calculator is one of those things that you may forget it exists, but it hopefully is helpful for that once every few years when you do need it. So there's a lot of tools in development, and there's a lot of tools that I think will really enhance CRRT quality, and I think AI is going to play a big piece in this. So CRRT is ideal for digital tools because it's often protocolized, there's a lot of calculations, and we have those rare scenarios, and I think it offers a lot of unique value proposition because it can ensure high quality and give us that just-in-time support. I will always advocate that any tools that we make are free from commercial bias and open access, and I think that that's something I would call on the CRRT community to really advocate for as well, because those who need it most are often the ones who may not be able to access it if they're behind a paywall. I've put up some QR codes here and links for the simulators that I've shown you, and at any time I'm always happy to take questions, and feel free to reach out if there's anything else I can chat with about or answer about digital tools in CRRT and CRRT education. Thank you very much.
Thank you so much, Amrit, for this very nice demonstration. And we have just a few minutes left to take questions. So I will let my dear friend, Dr. Craig from South Africa, to moderate just a few questions, try to answer those. But the rest of the question and all your inquiries should be addressed in our next week virtual workshop.
Right. Good evening, everyone. That has been quite a mouthful from all of our speakers, and I think your CRRT is really a lot about, as we've seen, it's a lot about various protocols, various calculations, doing various settings, and having quite a few varied approaches to certain problems. And it boils down to, what your goals of treatment are and what you're trying to achieve with a prescription. We've got a few interesting, very few questions on the Q&A, but there are one or two that obviously indicates, where people are struggling. And maybe we can ask Dr. Kamal Al-Attar, in your presentation, particularly about, the option of how you decide on CRRT dosing. Would you say that there's a big difference between using very low level dosing versus the kind of dosing that we are being told to use versus using a one dose or one size fits all? I know there are lots of, we're teaching to a lot of students from different countries where there may be resource constraints. Some practices are being told that you can only use a certain amount of replacement fluid or a certain amount of dialysate for resource constraints. What is the importance of dosing in CRRT, high versus low, and where are the cutoffs?
Very difficult question, but I will attempt to answer. Of course, CRRT dosing has been an area of research in the past maybe 30 years. So we've been looking in chronic dialysis, we have the KT over V, so we already know how much dialysis dose we are delivering. In CRRT, it was very extensively researched with 3 large randomized controlled trials, one in the US, one in Australia, New Zealand, and one in Europe, and all 3 randomized controlled trials came up with a optimal delivered dialysis dose of 20-25 ml per kg per hour. Again, this tells us that probably this is the right dose. We always try to target to prescribe more to try to achieve 20-25. Once you get more experienced, your downtime becomes less. So when you change the bags, you can change them faster. You try to keep the patient, on CRRT as possible. In this case, you may even prescribe 25 ml per kg per hour to achieve 20. Nevertheless, the problem with ICU patients is that they're all the time disconnected for different reasons. They are 1 hour they are sent for X-ray, the other hour they are sent for surgery. So it's a very dynamic environment. And if we do prescribe much lower doses, our delivered will maybe even lower. So in this case, depends on how often do you see that patient interrupted, the clotting, the changing the bags, and how often do you see that patient disconnected and so on. So, the answer for the time being, as far as we know, a delivered dose of 20-25 would be your target.
Good. There's a common question that we get is this question about the blood pump speed. Any one of our presenters is welcome to answer here. But this is often something that is asked of us very frequently. Is there really a big difference between choosing your blood speed, particularly for dosing? And I think that might be one of the concepts that needs to be clarified, is that there may be the conceptualization that increasing blood pump speed increases the dose and the effectiveness of delivery of dialysis. Can anyone comment on that?
Absolutely. We always get the pump question, and you and I were discussing that earlier. Yes, blood pump speed in CRRT has nothing to do with the efficiency of the treatment. In HD, the number one thing we do in intermittent hemodialysis in the chronic patients to improve the clearance is to increase the blood pump from 250 to 300, 300, 350. These kind of increases improve the clearances very much in intermittent hemodialysis in chronic patients. In CRRT, if you want to improve the efficiency of dialysis, the number one thing you do is increase the dose, the CRRT dose, from 25 to 30, from 30 to 35 ml per kg per hour. Increasing the blood pump speed will not result in higher clearances of urea, creatinine, potassium, or anything else. The only way we choose the right blood pump speed in heparin anticoagulation, like I explained today, actually we all explained heparin prescriptions today because this is the number one anticoagulant in this part of the world, of course, is to try to decrease the filtration fraction or the likelihood of clotting in those patients. So you adjust the blood pump speed to deliver a reasonable filtration fraction to avoid the clotting. Globally, when it is citrate, which is the main anticoagulant worldwide, we adjust the blood pump speed built on the citrate dose. So in both cases where we are adjusting the blood pump, it has nothing to do with the efficiency. In both cases, we are doing it to be able to have a longer filter lifespan, proper citrate delivery dose in the citrate mode, and less likelihood of clotting when we are doing heparin or in most cases zero anticoagulation, which is a lot of the patients in the ICU are doing right now, zero HEP prescriptions.
But do you agree, Dr. Kamel, also that if you increase the blood flow rate, it doesn't compromise usually on the patient hemodynamic because it's all extracorporeal circuit, so the amount of blood that's outside the body is the same, and the impact of increasing the QB on the patient hemodynamic would be minimal?
Absolutely, absolutely. And this is one of the, let's say, urban legends. When you start RRT, that increasing the blood pump speed, the patient will extremely, start collapsing and go into hypotension. Let's look at it from a circuit point of view. So blood left the patient's vein and is back to the patient's vein. So it's a closed circuit. If the cardiac output of this patient maybe is 5 liters, let's say his total blood volume is 5 liters, the circuit is 200, 300 cc. So this 5.2 or 5.3 cc liter circuit will not change. It will be always a closed system. Whether the blood pump is running fast or slow will not exert any pressure on the patient's actual circulation, nor the heart, nor anything else. The only time we should be careful with the blood pump speed is during takeoff and landing, when we are connecting the patient or when we are returning the blood of the patient. These are the two periods where the circuit is open, where we have breached that closed circuit. When we are connecting the patient, if you're going to be giving him saline, this is the period where you're going to be adding 200 or 300 cc's to his circulation. And that's where we advise the doctors and nurses to prescribe low blood pump speeds during patient connection. Start by 50, 60, 80 ml, and then gradually reach your target blood pump speed. Same thing with when you are returning the blood to the patient. Again, the circuit is open. Again, you're bleeding out the patient at the rate of 200 or 300 cc's, and that rate should be slow because therefore you've opened the circuit. But if the circuit, or once the circuit is closed, once you have a closed circuit, 100, 200, 300 ml per minute is not going to alter your hemodynamics.
Thank you so much. So it doesn't have any significant impact on patient hemodynamic. It doesn't have any significant impact on dialysis adequacy when it comes to CRRT, not intermittent HD. Thank you.
Thank you.
Okay, Dr. Mahmoud, maybe we can ask you a question or two. You presented some very nice cases, and I think we always present the problem of citrate. When we do any problem of citrate dialysis, we always present one of the problems. Can you comment and tell us how safe is citrate hemodialysis? Since we're always trying to troubleshoot problems in citrate hemodialysis, is it a worthwhile procedure to learn And is it a safe procedure to implement into your ICU?
Mahmoud is in ICU. I think he's busy with the patient.
Oh, okay.
I think me or Dr. Kamel or Jacob or Marcus can handle this too. I mean, I would say that, okay.
Professor Groman has the biggest experience with citrate, but I will comment on the case, the citrate accumulation case, which we saw. And citrate accumulation is a very, very rare metabolic disturbance of regional citrate anticoagulation. In literature, it is less than 3% of the cases. Even in literature of patients in liver failure, it is below 5%. So we're talking about a very rare metabolic disturbance that happens during a citrate anticoagulation.
So it's very safe. Only in patient with severe liver failure, yeah, it might. But we are monitoring the patient. But the major difference is it's RCA, it's a regional citrate anticoagulation. I have a question from one of our fellows a couple of weeks ago, and I was discussing with Dr. Kamel after. There is a huge difference between heparin anticoagulation and other ways of anticoagulation because these are systemic anticoagulation. Heparin goes to the patient blood. It increases it, or it might increase the coagulopathy. It's secondary or iatrogenic coagulopathy. So it can be associated with higher bleeding risk. But when it comes to regional citrate anticoagulation, the citrate just anticoagulate the extracorporeal circuit. So it shouldn't induce coagulopathy to our patient. Marcus, you want to comment, right? I see your face.
Yes, so I will comment regarding the safety of citrate. Very short. So it is very much dependent on the team, the knowledge of the team and experience of the team of this regime. So when the complete ICU team is very well into the citrate regime, there will be no change and no difference in the safety compared to other regimes.
Absolutely.
Completely agree. Yes, I agree with that.
Way back in Sweden, and he started another program here in Emirates. So definitely now, with the level of expertise of staff, metabolic disturbances will be much less, and of course, the serious complications will be much.
True.
We only have 1 minute, Craig. If you have any further question within a minute.
Now, I think there are lots of questions about whether we would cover certain topics in pediatrics. Maybe you can quickly just comment on that.
Yes, I mean the principle and the basics, troubleshooting prescription, vascular access problem. There is a lot of similarities, but also we have pediatric nephrologists who are going to teach. So this will be also something that we are going to teach. Yeah, we'll have both students, attendees, and faculty from the pediatric nephrology side.
All right, so I think I'm personally looking forward to this crash course myself. I'm one of the presenters, but I'm looking forward to it. And I think everyone who is we've got quite a few participants. We hope we see you there. I think you are all in for a really, really super class, masterclass crash course. And, we all are really geared to not only present to you the basics, which, everything starts with basics, but we want to go from basics to advanced and hopefully guide you all to be experts in this very wonderful life-saving modality.
See you next week.
Thank you, Craig. Thank you, Kamel, and all of our tutors, board members, educators, and of course, our attendees today. And we'll see everybody next Tuesday and Wednesday. Thank you. Have a good night, good day, good afternoon. Bye.